Hi, and welcome to my presentation on schizophrenia spectrum disorder. I recently graduated and passed my exam 2 weeks later. I'm in the process of licensure and socially isolating for the pandemic, so I'm reviewing my notes, and I thought I would share my notes in this presentation with others so they can pass the exam. I will be covering symptoms of psychosis, etiology, neurotransmitters and pathways, differential diagnoses. I'll be talking about various symptoms, the spectrum, principles of administering antipsychotics, how to promote adherence, and when to switch medication. So symptoms of psychosis include hallucinations, false sensory experiences without an external stimuli. They can be auditory, which are the most common, visual, tactile, olfactory, and gustatory. Delusions, which are firmly held, false beliefs despite evidence to the contrary. And there's several types of these. Persecutory is the most common one. Disorganized thinking and speech, so that'll be problems with information organization and interpretation that is best assessed in the speech patterns of patients. Loose association, derailment, speaks tangentially, and word salad. More symptoms include disorganized behavior, usually unusual behavior, ranging from childlike to rage, silliness, unpredictable outbursts. Their clothes will be disheveled, odd dress, inappropriate sexual activity, stereotypic motor activities, referential thinking, beliefs that events, actions, and situations hold special meaning, illusions and misinterpretation of actual environmental stimuli, and there's different types of those. So the etiology is multifactorial. There's a strong genetic component. First of all, only 1% of the population is the incidence is 1%. In monozygotic twins, if one twin has it, there's at least a 50% chance the other one will have it also. And neurodevelopmental factors include abnormal neuronal cell development, connection organization and migration, can result from genetic or intrauterine exposure to toxins, oxygen deprivation, malnutrition, substance use, and viruses. Neurobiological defects include abnormal brain structures, and CNS infections early in childhood is another contributing factor. There are higher incidents in urban areas. If you're born in urban areas, if you're firstborn, lower socioeconomic status, if you're born in the winter and early spring, and it occurs more in men than women. So transmitters and pathways, this is something that you're just going to have to remember by rote. Excess dopamine in the mesolimbic pathway is responsible for positive symptoms. Decreased dopamine in the mesocortical pathway, responsible for the negative symptoms. There's also an excess of glutamate and decreased GABA. The tuberofundibular pathway is responsible for prolactin um, responsible for prolactin associated with dopamine inhibition. So once you give second generation antipsychotic, especially risperidone, there's a chance that you will develop breasts and you can produce milk from that pathway. Okay, here's the differences between men and women. Men have a younger age of onset, 18 to 25 years. They tend to experience more negative symptoms, and they tend to have a worse prognosis. There's more hospitalizations, and they're less responsive to pharmacologic treatment. Women, on the other hand, they're about approximately 5 to 10 years later. They tend to have more dysphoria than men, and they have a greater incidence of paranoid delusions and more hallucinations than men. Now, I did not put children on here. Children have a worse prognosis, and it's a whole different ball of wax and very, 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 very rare. So I'm not going into that. The primary thing that you need to know is that it's extremely rare. And the antipsychotics are, there's less evidence for that, and they have worse outcomes. Okay. So early onset, like I said, they're typically men. They typically have poor pre-morbid functioning. They have greater negative symptoms, greater cognitive impairment, and they have a worse prognosis. If it starts a little bit later, they're typically female, less evidence of structural brain anomalies and abnormalities, and they tend to have less cognitive impairment, and women have a better. Okay, and here's a list of the positive and the negative symptoms. The primary thing that I want to say here are positive symptoms are things that never were there. They're such as hallucinations, delusions, the odd behavior, mania, suspiciousness, and they generate from the mesolimbic pathway. The negative symptoms are coming from the mesocortical pathway. That bit of information is important for the exam. And these negative symptoms are already behaviors that are diminished, such as flattened affect, alagogia, poverty of speech, avolition, apathy, and stuff like that. So, okay, here's the phases of schizophrenia: the premorbid, which is delayed motor milestones, abnormal neurodevelopment, poor scholastic performance, reduced concentration and motivation, passivity, depression, anxiety, irritability, anger, sleep disturbance, social withdrawal, and there can be some bedwetting. So that will progress to the prodromal, which is marked by peculiar behavior, inappropriate expression of feelings, behavior, speech, ideas, suspiciousness, and deterioration of functioning. And it progresses to acute or psychotic phase. And hopefully you're going to progress to stable or residual. There we'll go on to talk about the timeline and how this plays into the timeline. So this is not an exhaustive list of the differential diagnoses. Here's non-psychiatric stuff. What I did not put in here is with a new psychosis, the easiest thing to do for someone is to give them a urine drug screen and find out if this is drug-induced. the second thing that you're probably going to do is get a scan of their head, an MRI or CAT scan of the head, to find out if there's a stroke or neoplasm or something else going on inside there. So here's some non-psychiatric things to rule out. Epilepsy, CNS neoplasm, AIDS, acute intermittent porphyria, B12 deficiency, heavy metal poisoning, and neurosyphilis, Wernicke's Korsakoff syndrome, and some other things there. These are psychiatric conditions to rule out, and like I said, I'm not going to say that this is exhaustive because there's a lot, but these are the more common ones. Bipolar affective disorder, substance-induced psychotic disorder, mood disorders with psychotic features, schizoaffective disorder, schizophreniform disorder, brief psychotic disorder, and schizotypical personality disorder, and some other personality disorders. I'm not going into the schizotypical personality disorder in this discussion, but those are people that are strange, and I'll suffice at that. And perhaps I'll do another one on personality disorders down the road. Here's the timeline. Brief psychotic disorder lasts from, and this is also very high yield, lasts from 1 day to 1 month. A delusional disorder lasts at least 1 month, and schizophrenia form is at least 1 month, but less than 6 months. So, and schizophrenia symptoms are present for greater than 6 months. So when you initially come in, you're not going to be diagnosed with schizophrenia unless you've already got a previous diagnosis and you've had the symptoms. There will be a prodromal phase, and some people completely come out of the prodromal phase, and others don't. Okay, so here's the continuum again. The brief psychotic disorder. The symptoms include hallucination, disorganized speech, disorganized behavior, or catatonia. And like I said, this is 1 day, but less than 1 month. The individual always returns to premorbid functioning with a brief psychotic disorder. It's an abrupt onset, often in response to stress, and returns to premorbid functioning with treatment or removal of the stress. And that will be treated with an antipsychotic. All right, delusional disorder. They're generally high functioning with isolate, non-bizarre delusions, and they can be culturally defined that are well systematized. They last at least 1 month. The criteria for schizophrenia has never been met, and there's various types: erotomanic, grandiose, jealous, persecutory, somatic, mixed, and unspecified. Schizophreniform disorder, again, the criteria. Oh, this is wrong here. The criteria for schizophrenia has never been met. That's wrong. And the symptoms last at least 1 month, but less than 6 months. It includes a prodrome, active illness period, and residual symptoms phase. Does not require impaired social or occupational functioning for diagnosis, though it may be present. 33% recover within 6 months, and the rest progress on to schizophrenia or schizoaffective disorder. I saw somebody who worked nights in a grocery store because he couldn't deal with all the social stuff during the daytime, but he was a very reliable worker on the night shift. So that's how we kind of got around Okay. Schizoaffective disorder. It meets the criteria for schizophrenia in conjunction with a major depressive disorder or bipolar disorder or mixed mood episode. Elderly tend to have the depressed type. Men tend to exhibit more antisocial behaviors. Oh, I don't know what that one is. Okay. Risk factors include family history of schizophrenia or bipolar, and this one needs to be treated with an antipsychotic and an antidepressant or mood stabilizer. And this one here I've not seen. It's folie à deux, shared psychotic disorder. It's a delusion in a patient who has a close relationship with another one who already has a psychotic disorder with a prominent delusion. Usually the other person has schizophrenia. And this, they're in a long-term intense relationship. The person with the psychotic symptoms is dominant. And aside from the delusional content, the patient's behavior is otherwise normal. The prognosis is better when they're separated. So I saw this in a woman who had said that spaceships were coming into her house and bringing her into the spaceship and doing surgery on her, etc., etc. So she would get up if she felt like spaceships were there. She would get up in the middle of the night, wake up the kids, and take them down to Kmart parking lot. So they were having folie à deux. So I guess I have seen that one. Here's some various symptoms that Stahl talks about addressing: affective symptoms, positive symptoms, negative symptoms, cognitive symptoms, symptoms of aggression. There's also another one, and that is side effects. Okay, principles for using antipsychotics. I'm not going to go into antipsychotics specifically, but I've got principles for using it there. I may do a presentation on antipsychotics, just not right now. Okay, so attempts are, we want to attempt to use manage with monotherapy, as in all things. All patients should be monitored for metabolic and motor side effects. First generation antipsychotics are better for negative symptoms, and the reverse second generation antipsychotics are better for the positive symptoms. Generally, the first generation antipsychotics have more Parkinson's symptoms, motor side effects, and second generation have more metabolic side effects. Medications should all be individualized. I'll be talking about that in a little bit. Antipsychotics should be effective, safe, tolerated, and of course evidence-based. Consider their personal preferences and vulnerability. Can be very difficult to work with people who don't want to take it because of the side effects. Consider the economics of medication. If they can't afford it and they don't have insurance, then they're not going to be using it. Medication choices should be informed by best evidence. And I'm just going to put in a plug for clozapine. Is consistently outperforms other antipsychotic medications, both typical and other atypicals, in the management of treatment-resistant schizophrenia, but is not first line, and we all know why. And if you don't know why, we'll hopefully get to that soon. Clozapine is talked about over and over again. There's some very strong side effects. It needs to be monitored real closely. And and it's not a first line one. It's just epic. Okay, so we all want to encourage adherence, and that can be done by shared decision-making, recovery-oriented approach, community case management, and also involving and educating the family members and the patient. There is a better success rate when family members are actively involved in their recovery. Unfortunately, there are times when medication will have to be switched, and switching antipsychotic medication in schizophrenia carries significant risk and should be undertaken carefully. Continuation of an agent in the absence of desired benefit and/or occurrence of significant adverse effects, however, is also inappropriate. In the context of inadequate efficacy and/or safety tolerability, carefully considered and informed switching suitable alternative agents should be considered. Okay, so that is all that I have, and check back later for some other videos that I'll be making. Thanks and have a great day.